All right, good afternoon, everyone, and welcome to today's very timely discussion on the recent CMS RFI surrounding the proposed changes to the organ transplantation requirements for participation in Medicare and Medicaid programs. My name is Deanna Fenton, Senior Manager of Educational Program Development and Operations here at the Alliance, and it's my pleasure to be here today to kick off the program. Now, the intended goal of today's discussion is to raise awareness about the potential changes to the transplantation requirements and engage all of you in a dialogue about the potential impact that these changes will have on organ availability and access and your organization's operational practices. Now, before I turn the floor over to our panelists, I'd like to welcome the Alliance's Executive Director, Carrie Hobson-Pape, to share a few words. Carrie?
Thank you, Deanna. As Deanna mentioned, my name is Carrie Hobson-Pape, and I have the honor to serve as the Executive Director of the Alliance. We would like to extend a special thank you to Jennifer Milton and Tricia Jones at University Health in San Antonio for bringing this important topic to our attention a few weeks ago and recommending this program today. We always welcome emerging topics that are important to our community, so we encourage each of you to share your recommendations for learning programs in the future. In addition, the Alliance does not take a position on issues and always intends to maintain a balanced and objective perspective while bringing critical topics to the community for important discussion. So today we are very happy to partner with AST and AOPA to share this information. Finally, all of the material shared today will be posted after the program to the Alliance Community Resource Toolbox on our website, which is organdonationalliance.org under Resources. So with that, I'll go ahead and pass it back to Deanna to kick off the program.
Thanks, Carrie. Now, before we begin, I'd like to encourage all of you to take advantage of the chat feature should you be interested in joining the discussion to share your own insights. Likewise, should you have any questions that you'd like our panel to address, please feel free to submit them at any time using the Q&A box. For those of you who may be new to Zoom, please note that both features can be found in the Zoom navigation bar at the bottom of your window. Additionally, for anyone joining us today as a group, we'd like to ask that you take this opportunity to complete the following poll to indicate approximately how many people have joined your group. Now, for anyone that may be interested in our upcoming programs, we'd like to share that registration is still open for our next transplant focused webinar next week on navigating survivor's guilt. You can join us for that on January 27th at 3 p.m. Eastern as we explore several techniques to support transplant recipients and help them understand the positive impact that donation can have on the grieving process for donor families. Then in February, we'll kick off with our next donation-focused webinar, where we'll explore how to engage your hospital partners to lead policy change and ensure successful donation outcomes. You can join us for that discussion on February 8th at 2 p.m. Eastern. Now, to learn more about either of these webinars or any of our upcoming programs, please visit our website at organdonationalliance.org. Now, please note that while we will not be offering continuing education credits for today's program, we highly encourage you to claim a certificate of attendance. Prior to receiving your certificate, you will be asked to complete a brief online evaluation, which will give you a great opportunity to provide us with your valuable feedback. Now, if you happen to be listening in a group, please be sure to get the evaluation email from your group lead. And as a friendly reminder, you'll have about 30 calendar days to complete your evaluation and claim your certificate. Now, if at any point in time you experience any issues with the platform, please don't hesitate to contact us through the Zoom chat or through the general inbox at info@organdonationalliance.org. Now, at this point in time, I'd like to welcome our moderator, Linda Oler, Quality and Regulatory Manager at George Washington University, who currently serves on the Board of Directors of the American Society of Transplantation. Linda, we really cannot thank you enough for all of your efforts in coordinating today's program, and we appreciate you being here today to facilitate the discussion. So with that, I'll go ahead and turn it over to you.
Thank you, Deanna. First, I would like to thank the Alliance for providing us with a platform to discuss this important ask from CMS. This is an excellent opportunity for us to provide information and education about organ and tissue donation and transplantation from our hands-on perspective to CMS. They're asking for our thoughts. And I think it's the first time I remember them asking. Usually they put out a proposal and we respond to it, but this is a wonderful opportunity for us. So consider yourself an expert and send them your thoughts and your experience on each of the questions they're asking. In today's program, we're going to hear from an OPO and transplant leader about this opportunity to provide CMS with the feedback they're requesting. Jan Finn will respond to questions from CMS regarding the organ procurement and donation, and Luke Przewski will address some of the issues CMS wants to learn from transplant programs. Luke is on the AST Public Policy Committee. AST has sought feedback from members of the Board of Directors, its Public Policy Committee, and the Transplant Community Advisory Council. That's really a group of organ recipients and living donors, and that's who CMS wanted to hear from. They wanted to know the patient's perspective. So if you read through the document from CMS, they want the patient's voice in the responses. So AST has requested that, has had patients responding, and I hope you will too from your transplant centers and the OPOs for donor families. AST leadership is developing a summary based on this input and will post the document on the AST website, hopefully in the next few days. It is a great pleasure now for me to introduce two colleagues who will address questions asked by CMS in the RFI, the request for information. Our first speaker representing our organ procurement organizations is Jan Finn, and she will be followed by Luke Przewski. Jan is the current president and chief executive officer of Midwest Transplant Network. She has served on numerous boards and committees, including the UNOS OPTN Board of Directors, NATCO Board of Directors, AOPA Annual Meeting Chair, the Health and Human Services Advisory Committee on Organ Transplantation, UNOS Patient Affairs Committees, and the Missouri Governor's Advisory Council on Organ and Tissue Donation. She's currently president-elect for AOPA, the Association for Organ Procurement. Jan holds a Master of Science in Nursing from the University of Kansas, as well as other professional degrees. Luke Przewski is the Vice President of Miami Transplant Institute, MTI, a unique affiliation between Jackson Health System and the University Health, the University of Miami Health System. Prior to joining MTI, Luke served as Executive Director of the Transplant Center at the University of California in Davis Medical Center. Prior to that, he served in the as an Administrative Director of the Comprehensive Transplant Center at Northwestern University in Chicago. And I think he's happy to be in a warmer weather right now, especially since it's so cold up north. He also has been a member of the executive committee for the community of practice for AST's transplant administrators and quality managers for the last 3 years. And he also serves on the public policy committee for the American Society of Transplantation. At this time, I'm going to turn it over to Jan Finn. Jan, would you please give us some insights?
Well, thank you, Linda. Thanks so much for that great introduction. I'm actually currently the president for AOPO, so it's nice that it's on this slide, but I am representing AOPO and attempting to bring you some information about the questions and some of the responses. I also want to incorporate some of the questions that were asked when you all registered. We had a really great number of questions. And so as I go through some of these slides over the next about 10 minutes or so, I will incorporate some of those as well. So one of the things that I think Linda really outlined well is that AOPO is very happy that we are able to provide input. This is a great opportunity for all of us, and also to show our support for this effort. So AOPO firmly supports improvement. We want the most equitable and fair transplant system, one that's efficient. And certainly now in this environment, we are really thinking about equity in donation and transplantation, as that is one of the hot topics in the country, as it should be. And our opportunities through AOPO to be able to impact that. And so we're looking forward, we're working hard on our comments right now to be able to provide those, because what we really are attempting to do through all of our work is to incorporate some of the best practices that are known. We know that the donation and transplantation system is one of the best in the world. The best in the world is how we're going to say it too, with over 41,000 transplants last year, the first time ever. I know that that's not news to any of you as you follow this very closely, because this really means lives saved. these are the impacts that we are making on a regular basis. So when we think about equity in the organ donation and transplantation space, some of the questions that were asked by CMS, and I will say that we most recently had a call with CMS, and they were very eager to learn. They want to have our input. They want to make the system better. And so as Linda outlined that, it really is important that each of us as OPO leaders or in transplant centers put forward our comments as they ask for our reactions to these questions. So really thinking about some of the revisions that could be made and some of the programs that could make this better. When you think about the social determinants of health for individuals, many times it's about just having enough food to eat. But if you're a transplant recipient or potential transplant recipient, it's also how do I get on the list? How do I make sure that I have all of my abilities to get the testing done and things of this nature? So I know that Luke will probably speak to some of those things. But on the organ donation side, it's really about how we can make sure that the system is equitable. So through AOPO, one of the tenets that we have determined that was really important in our work is to have a formal DEI committee. This committee came out of a task force that Dr. Harry Wilkins led last year and came up with a full assessment that AOPO could provide to our members so that we can make sure that on our side, on the organ donation side, that when we work with donor families, that we are culturally sensitive, that we have great practices in place in putting forward a community that supports donation. You know, we were looking to some of our leaders across different OPOs to think about what some of the best practices they have. There are many OPOs that have very dense multicultural communities, so they would have the best opportunity to provide information to CMS about how that could be made better and maybe some practices that all of us could implement. We don't want there to be barriers in any way. And certainly an underserved community has many barriers when we think about equity and donation and transplantation. The donation side seems to be somewhat easier. So I think Luke will probably be able to speak to the transplant side and how some of these comments that we're making would be able to influence the system and make it better for this population. So definitely a very important issue and one we wanted to bring forward first because it does seem to be something that is very relevant, obviously, at this time. When we think about OPOs, you know, one of the questions that was asked was actually when these changes are made, because we all are very well aware that there were changes made, there will be with the metrics. Was that a motivator? Was it something that was going to make change and improvement, because they are very different things, or was it something that was really motivating or distracting? And so I want to speak to that and just say that I know that through the last couple of years, when we have been looking at the metrics and knowing that change was coming, outcome measures were going to be looked at differently, I do believe it's a call to action for us as OPO leaders and OPOs to just do our very best and put resources in place so we can continue to drive the donation system forward. And that has happened over the last 2 years with steady growth. It certainly has happened in the number of transplants that have been available. So I think calling attention to these and looking at the models of high performing OPOs has been helpful. We'll be able to comment about that. You know, there are always best practices in OPOs. And if you're not communicating and you're not aware of the data, it's difficult to know what others are doing across the country. So AOPO, as one of our tenets also, is how do we educate and how do we bring forward best practices? So looking at those types of things, certainly looking at OPOs that are high performers in terms of the current metrics. It can't be lost on the fact that we currently are in a recertification cycle. Every OPO will be visited this year, probably before August, an unannounced visit, just as many of you are very familiar with. And so we need to be ready. These are going to be things that are evaluated from the current certification process, not those that will be evaluated on in 2026. So when we think about this for OPOs, it has been a concern because when the new metrics were rolled out, recertification also had an impact on possible decertification. And I'm sure you're very familiar with the news and how there are a lot of comments about an OPO has never been decertified, when the fact of the matter is that has happened many years ago. But that's really not the goal of CMS. The goal of CMS is to improve performance and to put the best foot forward for the patients that are waiting, and also for the donor families, to give them the very best opportunity to be donors. So when we look at mergers or expansion of OPOs, I think the concerns that we would bring forward and ask for more clarification on are how a merger would actually work. Well, how would it be determined that the very best OPO was chosen for this process? And how would it disrupt the current system or not? Maybe it is a factor that we enter into this knowing full well that an underperforming in the eyes of CMS on these metrics, an OPO that didn't meet the recertification guidelines was given to a high performing OPO, maybe a contiguous OPO or maybe not. And what would that impact be? So it's incumbent upon whoever that OPO leader and board and DSA is to make the very best of that situation and not cause disruption to the system. That certainly would not be a goal of anyone. The goal is to improve donation and to make more transplants available. Some of the other things that CMS has asked us to comment on are really relative to transportation of organs and tracking of those, and what are the best practices. Currently, there are many studies that are being evaluated, pilot programs to say, how can we track this organ? I think you've all heard the analogy that if you know when Amazon is delivering a package to your front door, there should be the same technology available for organs. These precious gifts that are given by others are in our control, and our responsibility as organ procurement and transplant centers to make sure they get to the right recipient. We never want an organ to be lost in transit, and putting a tracking mechanism in place that's effective is probably one of the most effective things that we can do. However, we have to look at the whole system and being able to give CMS information about the likelihood of an organ being lost. I'm sure that many of you, all of you probably, have been on an airplane in the last, let's just say 3 years because of COVID. But I've experienced many delays. I've experienced weather, plane issues, all types of issues of that nature. Those would affect the same things. So the system is not 100% perfect. The only way we could ever ensure that was to have an aircraft available just for the transportation of those organs. And I'm sure many of you are well aware of the issues with not having enough airplanes available just to recover organs. And then it's never 100% that those airplanes are going to be available at the right time and be able to deliver the organ. However, we know that there are many things that are being evaluated, such as drones and other ways to deliver organs. So hopefully there will be more information about that we'll be able to give CMS to really look at the transportation and tracking of organs. We realize that this is a very important issue. I do like the option of CMS being able to incentivize or possibly create additional mechanisms or ways to make this happen. So those of you that are in that space, certainly provide those comments to CMS. So a couple of things, zero organ donors and discarded organs continues to be a problem for all of us. And I will say that giving this information to CMS, when we first got our rankings, all of us, we looked at the number of organ donors. And I can tell you that every organ procurement organization probably looked at that very, very closely and saw the numbers didn't exactly match. When we have an organ donor recovered, we recover organs in the past. It has been if an organ, a single organ, was removed from the donor for transplant, regardless of whether it was actually transplanted or not, that was counted as a donor. In the new metrics, you will not be able to count the zero organ donors. And there's really not a definition, as CMS has told us, of zero organ donors. We all are very well aware that if an organ is not transplanted, it does not count. And so that's a zero organ donor. There are a lot of factors that really factor into this. I can tell you from an aggressive OPO, I would say that we're very mid-sized. We have 5.5 million population. And so we are looking at every opportunity to make sure that we not only offer the option of donation to families in full disclosure about the opportunities that they have. There are issues where organs are discarded. There must be an acceptable rate. So I think CMS is saying, what is an acceptable percentage for organs that are discarded? That's a very difficult measure for us to be able to give good information on. We know that varies across the country. There are a lot of reasons why organs are discarded, and there are issues why there are zero organs transplanted from any donor. Every effort is made, I can tell you, to transplant every possible gift. However, organs possibly are damaged on recovery. Organs are deemed unsuitable after they are recovered. So there will be instances in situations where organ donors go to the operating room, full intent to recover and transplant organs, but we're not able to do that. And those result in discards. So one of the things we're excited about too is that with the new learning collaborative, it's really focused on kidneys. The highest number of discarded organs is kidneys. So that effort will definitely be looked at, and across the country, the goal over the next 5 years is to decrease that rate from about 20% to 15% for kidneys alone. And we know that anyone that's on dialysis, those kidneys are precious gifts, and everything we need to do to maximize that gift for others when there are 106,000 people waiting for a kidney is important that we do. So also CMS wants to know about donation after circulatory death or cardiac death and why the rapid increase. You know, this increase has happened over a number of years. If you think back to the collaborative, those of you that were around in 2005, it was a relatively small percentage and has grown tremendously over time. That is because of the great best practices that were initiated, developed, the whole country really around OPOs and transplant centers working together to make sure that we were able, number one, to offer this option to families, maybe in a very different situation. There are many patients that don't meet brain death criteria, but could be donors after cardiac death. So a great opportunity for that. There are challenges with that. We'll inform CMS about some of those challenges. One being the difficulty in being able to always have a surgeon available or someone available to recover. And also, most importantly, someone to pronounce the patient that is separate from the surgeon. So it is a drain on the hospitals. It is a difficult task. These are complicated situations and ones in which we must make sure that everything goes very clearly and carefully. The push from the OPO side to the transplant center side has been accepted very well. And that's another reason why the rapid increase, or just gradual and then seemingly very rapid over the last 10 years. Because of the expansion of the transplants. At first, there were kidneys that were transplanted. And now, as many of you know, hearts, lung, pancreas, various organs, liver can be transplanted. Not easy, not always a very smooth process when we're dealing with emergent situations. I know that we had one of those yesterday in our own service area where we needed to go to the operating room fast. And so a DCD donor moved very, very quickly. But the end goal is always to get an organ transplanted and to save a life, to improve a life, and certainly to help that donor family. Some of the other things that OPOs have been asked to comment on are organs for research. One of the questions that came up from those of you that registered were the types of organs that were being considered for research. Currently, it is only the pancreas and pancreas for islet cells, but hepatocytes or liver possibly could be counted. At this point, CMS has not made a decision about that. So those are certainly things that we will comment about. The donor referral process, obviously streamlining that. One of the questions was, is there a cost to that? There can be a cost when you think about it, cost to the entire system from adding tracking, but in the referral process, electronic referrals, those are not without a cost for the development or the implementation of that. And so certainly looking at how we can streamline the referral so that we get the offers earlier or just the notification and can be on site sooner if possible to talk to the families to help manage the process. Many things that we could be doing to help with the referral process. So we'll be commenting on that as well as organ recovery facilities. There have been organ recovery facilities. Our neighbors, close neighbors in St. Louis have been doing this for 20 years. And so they're very well versed in this and have great data to show, as many others do, that have organ recovery facilities, decreasing cost, increasing the number of organs that are transplanted, maintaining the donor family satisfaction. So it's important that we comment about those types of things because it can help the overall system. Certainly our relationships with tissue banks and how do we make sure that we are keeping everything in the forefront, whether it be an organ donor, also the tissue and eyes that are recovered for transplantation, and then also looking at vascular composite allografts, considering whether those would be an organ, actually counted as an organ, and so putting forth comments such as that. So it's been a very quick process in many ways. We've had the request for information for about a month now. So AOPO is working on the comments, as I mentioned. We are moving quickly to get those approved and to get submitted to our executive committee so that we'll be able to help all of the AOPO members in sending out these comments. We'll share a draft with them so they can use it as a template to be able to inform themselves and in making their own comments. Ours from AOPO will come through the approval process from the executive committee. We will be holding a webinar next week for our AOPO members because the comments need to be submitted by February 1st, which will come around very, very quickly. So I'm not going to answer any more of the submitted questions at this time. I'm sure we'll have many more. So Linda, I'm going to turn it back over to you as the moderator, and then we can move forward unless there are questions that popped up as I was speaking, I guess. Linda, you're muted.
My apology. Thank you, Jan. I appreciate your answering a lot of the questions that were submitted as people registered. So that was a great idea. Thank you. And Luke, I would like to turn this over to you now. Luke is going to talk about the more transplant center perspective. Luke?
Thank you, Linda. I appreciate it. I would like to thank the Alliance for the opportunity to do this, and I appreciate their pulling this together on short notice, as they so often do on topics of interest, and grateful for that, as well as to both AOPA and AST for their work in this area. To add as a caveat, so my prepared remarks and presentation should be relatively non-controversial. Any responses to questions, that's always a risk with me. My comments are not on behalf of AST or Jackson Health System, but my own as a longstanding member of the transplant community. Right. So I want to give a quick historical perspective. Most of you know this. In 2007, the CMS conditions of participation for transplant programs were unleashed based on the final rule published in the Federal Register that year. There was an extensive period of public comment and a lot of response from professional organizations as well as many transplant centers. These resulted in the final set of interpretive guidance that got put out to the surveyors who did that work. And at the time, it was issued to the states. It's been a little back and forth in terms of whether it's been surveyed by the states, by a federal contractor, some combination of both. And we're back now to those being surveyed by the various states, which does lead to some variability in how the interpretive guidelines are handled. The interpretive guidelines have been revised extensively in 2008, 2016, again in 2019. There has been variability in the degree of responsiveness to comment when those things have happened. And some of the most recent revisions are actually it's still a little unclear in some cases what are the current interpretive guidelines. Some of them have are listed as sort of proposed changes, and it's in flux. We've had some good engagement at times on that, and some commitment to address some of the concerns raised by the transplant community, but then some of that has not happened. So we're in a little bit of an amorphous area in some of these areas. I think this RFI certainly signals the likely intent to make significant changes, and I think we should regard this as an opportunity to submit comments around what we would like to see. And I would also suggest that everybody who's commented on these guidelines that we've seen in the last few years, dust those off and consider resubmitting any of those as we go through this process, because it is an opportunity to get them to listen. So this RFI was put out in early December. It gives a deadline of February 1st for response. That's the minimum 60-day notice, which is typical, but as we know, especially over the holidays, does not give us a long time. Comments can be submitted electronically at regulations.gov or mailed. I recommend the electronic. It's easier and surer, but for people who really want to drop it in the mail, it is allowed, and the details of that are present in the RFI. So the overview of this is what they describe as what they're soliciting, the sort of the purpose of the RFI is to solicit comments on ways to do these 5 things, and they're fairly broad. 1, continue to improve systems of care for all patients in need of a transplant. 2, increase the number of organs available for transplant for all solid organ types. I think this, consistent with the initiatives that HHS has put out over the last couple of years, and some of the scrutiny that we've seen, particularly on the OPO side of the world, is likely a big driver and will likely be a big focus of what we're doing. I would expect some intent here to extend some of the regulations that are being put forth related to OPOs toward transplant centers, given a recognition that the OPOs can recover all the organs they want, but if nobody puts them into somebody, they're not doing any good. And in fact, as Jan noted, they may not be counting toward the OPO metrics through no fault of their own if no transplant center will use them. Encourage the use of dialysis in alternative settings. I'm going to skip this. It's not the dialysis portion of this is not really the purpose of today's call, although it's important. Ensure that CMS and HHS policies appropriately incentivize the creation and use of future new treatments and technologies. And finally, harmonize requirements across government agencies to facilitate these objectives, improve quality, et cetera. I think this is extremely important. This is an area that I and many others have noted over the years, that ambiguity among regulations, duplication among regulations is a very big deal. It makes our jobs harder in transplant centers to have, for instance, mismatch or duplication between CMS and UNOS, for instance, on our regulations. I think that's an extremely important thing for us to address. I joked for years about bouncing back and forth between a compliant ABO policy based on whatever our most recent survey was. So we would align it to one, and then we would get surveyed by the other, and we'd have to change it again. And for years, I got cited at multiple institutions. Have been cited on ABO out of not any desire not to be safe or anything else. It's just I've been unable to find a way to meet the conflicting regulations. I also think the harmonization aspect of this is intended, I hope, to apply to this idea of harmonizing the regulations for OPOs, transplant centers, and dialysis units, because they're often somewhat siloed and need to be thought of in terms of how they interact with each other. And I would certainly urge everyone to consider submitting comments around that to try to get harmonization across all the affected entities. They refer to it as the transplant ecosystem, and that's all of us. And I think consistent regulation for all of us would certainly be helpful. Specific to transplant centers, they lay out a lot of specific things that they're asking here. Again, many of these are very broad, and so I think it's important to consider a couple things. So one, that means really pretty much the entirety of the conditions of participation are fair game under what is being solicited here when you look at the breadth of the comments. And so I would urge people in commenting to be willing to go anywhere that they think the regulations need to improve. And I'm not going to read all this to you because it's all in the RFI, but I think that's important. This first bullet here, this is a continuation of the last slide because it didn't fit, but the industry as a whole has acknowledged that changes cannot be made solely to one part of the transplantation system. So this gets to a specific ask that they understand how to tie these regulations all together, and importantly, how to tie outcomes measurement together, and that we're all being measured against some of the same things. This next bullet is interesting in context of organ shortage. Again, we think this is a very, very likely focus of this is how to expand the use of this. And there is another section of this where they in particular note that they previously took away the recertification requirements based on outcomes. So why is it that we still care about our outcomes requirement? And then it is this continued comment that many of us in the transplant community have had over the years. So long as you publish outcomes on the web, so long as you are saying this is a 5-star program versus a 3-star program, and so long as insurers are using that to decide who to pay and who to put in centers of excellence, it's going to matter. Now, I'm not taking a position on whether that's right or wrong or anything else, but nobody should be surprised that if you publish ratings like that, centers are going to try to achieve the 5-bar outcome. And they are unfortunately likely to do that at the expense of utilizing as many organs as may be possible, given the extensive unadjusted risk that is present in the SRTR model. And this is not to disparage the SRTR. They do phenomenal work. They're probably, maybe they are a couple others with them are at the top of of really assessing health quality and publishing that. They do a tremendous job. However, they basically deny a need to address how that information gets used once it's published. And so I have heard the comment many times when I talk about, well, insurance companies use this to exclude us from Center of Excellence. Folks at the SRTR will completely correctly say, well, that's not our problem, right? We publish it. What people do with it is up to them. And that's fine. I don't disagree with that conceptually, but I think then we need to be clear in our comments that this is one of the reasons that simply taking them out from the CMS recertification does not make them go away as existential threats to transplant centers. So there's a lot in here about the patient rights regarding offers, and I want to focus on this. And I've highlighted some aspects of it. There is no requirement for the transplant center or surgeon to notify a patient on the waiting list that there has been an organ offered for them. And so I would urge everyone making comment to consider when they make a statement like that, they might be considering changing that. And so that means they might be considering a requirement that the transplant center or surgeon notify a patient on the waiting list anytime there has been an organ offered for them. And I think logistically that offers considerable challenges, and we need to think about the ramifications of something like that. They do acknowledge a need not to cause the patient undue anxiety. And so they do understand that it's not as simple as saying, oh, every time there's an organ offer, we have to tell the patient about every single offer. But they clearly want more regulation in this area, and they're seeking it. And we need to be very thoughtful in our comments on this, understanding the real operational challenges that would entail us having to tell everyone that in a match list that we technically turn an organ offer down for, that we've done that, because that is a huge number. And in fact, I have been mostly in fairly aggressive centers in my career. We technically turn down a lot of organs for a lot of patients, and it's not intended to disenfranchise them. It's intended to find very specific use for very hard to use organs. But when we go through and code out a large number of patients, if we had to call them all, we would have to stop doing that. And so I think there is a need for this to be very, very thoughtful, because it may very well, though well-intended, conflict with their intent to see an increased use of hard to place organs. So their specific question here that they would like us to answer is, how can transplant programs facilitate greater communication and transparency with patients on their waiting list regarding organ selection while limiting undue delays or undue anxiety to their patients? And so I think it's important that we are responsive to that. And it is not reasonable for us to just say, well, there's nothing more we can do. We're as transparent as we can be. That type of response is usually not a good way to avoid bad regulation. I think we need to be thoughtful. They clearly believe they need to address this, and we would be wise to give them some advice on how best to do that in a way that does not make it impossible or extremely challenging for us to do our work. There is a lot in reducing disparities. So that's been part of their goal, is to help understand what we can do to reduce disparities. I'm not making a comment on how we do that, but it is certainly a very complex issue. But we need to understand that that is a high profile item, and we need to be very thoughtful in helping them understand ways that they might be able to do that. And again, for us to be thinking of ways that are going to do that are realistic for us to implement. As we know, there are many drivers of disparities in healthcare that are not within the control of the transplant center, and we should be encouraging regulation that does ask us to do everything we can do, but doesn't ask us to do things that are impossible. And so be thoughtful about communication in that. So to summarize sort of my advice to people as they consider responding to this, and I'm glad to see literally hundreds of people on this, so I hope that means that there will be hundreds and hundreds of comments to CMS regarding this. And I'm putting it in a 3-word process: educate, advocate, and escalate. And I put educate first because they are sincere in asking for our feedback. They want it and they want to learn. In all my years of interaction with CMS, I have always found them interested in our opinion and interested, understanding that they don't know as well as we do what goes on at a transplant center or OPO, and they really do want to hear us and learn from us on this. So that's job one, is to help teach in responding to this. Second, we need to advocate for what's important to us. We know what's going to impact our programs, and much more important than that, what's going to impact our patients. And so it's very, very important that we be direct in advocating for those things that we consider important. And finally, escalate. And we want to believe that this process is going to lead to good regulations. We want to believe that they'll be responsive to us in whatever they do put out. But I would say that if we get to the end of that line and there are things in there that shouldn't be there and that really are a problem for us, that we band together to, as we have on many other issues in the past very successfully, to reach out to them, to use the professional organizations, to reach out to members of Congress and others, to do what we need to insist that these rules be the right thing for our programs and our patients. And so right now we're in the early part of that. Our response now should be heavy on the education, strong on the advocacy, but later we may need to move to the next level. And it's important that we be willing to see that all the way through to the end, and that we do all of this as a group. Some general statements related to public comment. They are required to listen to public comment, so it does matter. I've certainly had many public comments ignored in my life. However, they do have to read them, address them, and listen to them. They don't have to do what we advocate, but they do have to pay attention to it and respond to it. And they do, and they want to. So my experience is that they are legitimately interested in it, even sometimes when it doesn't necessarily feel that way. It is also important as a foundation for challenges. So if we do end up in that point where we're having to push any of these issues, appeal things, if we go to litigation, although I certainly hope that doesn't happen, but if it were to, what was put in the public comment is essential as a foundation for those activities. And in fact, the public comment process is one of the most common things that comes up in judicial appeal of regulatory matters. Be responsive to their questions, but don't feel constrained by it. So, they ask questions. It's good to answer them, right? But go back to the overall theme of this, which is very broad. If it's in the overall theme of this, it's in bound. Now, this is not a chance to complain about the IRS or, TSA. It's got to be restricted to, to things within this RFI. But this is a broad RFI related to the regulation of transplant. And so while we should focus in particular on answering their questions, we should also make an effort to cover anything that we think is important. We should focus related to that on the themes and goals. So don't get lost in the questions, focus on the overall themes and goals. Try to predict unintended consequences. This is always difficult, but do your best to be thoughtful about, even if we get well-meaning regulation, what are the things that though not intended are likely to come from that, and to be very direct about addressing those, because nobody wants them, but they've always happened with the regulations that we've seen in transplantation. And the more we can put that out there, the better the set of regulations we'll get. Volume matters, so we want a lot of people to respond. If they hear the same comment 100 times, they are more likely to consider it than if they hear it once. Our professional societies are awesome. I'm a big believer and an active participant in AST and the ASTS, NATCO, AOPA, others also do a great job of advocating. But one, as I mentioned, they count every voice. So that volume does matter. The professional societies are probably weighed higher than one individual, but all the votes matter. Additionally, the professional societies are trying to strike a balance on these things, and they're trying to be responsive to the entirety of their membership. And so that may lead them to not be in a good position to take a controversial position. If there's something that's important to you, say it. One of these organizations may or may not be able to say it on your behalf. Additionally, if there's something that's important to you and 20 colleagues, get together and all say it and say this is important to centers in the Southeast, for instance, or this is important to aggressive centers. Those may be things that the professional societies feel are not universal enough within the community to make as a comment. And remember, the transplant community can do this. And in fact, we have done this. We've been very effective in advocating for ourselves. We'd all like to be more effective, but I am very, very constantly impressed by the way this group comes together to advocate on important issues. And we've made a lot of very positive changes, and we've also warded off bad regulation a number of times. I'd like to leave you with two quotes that I think are particularly relevant to this. First, the road to hell is paved with good intentions. As best I can tell, we can't attribute that. I do believe that in doing this, our government regulators do absolutely intend the best, but the reality is all those best intentions can still sometimes lead to problematic things. Trying to do something that sounds good does not necessarily mean it produces a good regulation. And from the great philosopher Homer Simpson, in theory, communism works. So there are things that may make sense. You may think that you can regulate away disparity in healthcare. And I hope that's true, but I also doubt that's true. And so we need to be, tempering everything with some realism in what regulations we get, and are those actually practical, and are those things that we can deliver on, or are they more likely to produce unintended consequences for our programs and our patients? I'll stop there and hope to get as much discussion as we can, and happy to attempt to answer any questions.
Thank you both very much for this. They are difficult questions to answer because, like I said, they want the patient voice too. But we have to realize they are asking us questions that they are probably going to make changes in. So they're asking us for this. With the question on responding to each patient and letting each patient know that transparency, that was one that had me quite concerned. And we've been talking about it within our transplant center. And I went into DonorNet and I looked at just one donor, just one, in one night. And we had 64 possible patients that could have gotten that one donor's organ. And of those 64, they went up from sequence 5 to sequence 11,000 for a kidney. So, I mean, you have to look at this from a realistic standpoint. It would be really hard to comment to somebody at sequence 11,000. So we were talking about this at our transplant center, and we thought, what if I would want to know if I was on a list waiting for transplant, if I never heard anything for 3 years, I'm waiting for a kidney, or 4 years, and I've never heard anything. We were talking about combining this possibly with our waitlist management, that when the patients come in for waitlist management, that we give them a summary of the different calls that we've received for them and why we didn't turn them down. But even that's quite a bit to do. But anyway, it's something to think about. If they're going to change this, then we need to provide some ideas on and understand that, yes, it would be nice. Like I said, I would love to know if I've been on the list for 2 years and I haven't had a single call. I would like to know that at least there's been some offers for me. So how can we capture that and give that to our patients without making an extensive amount of workload for our staff? Somebody says here, I'm reading from Bradley Adams, to the point that volume matters, and it does. Are there ways in which the donation community and the transplant community can amplify each other's messages to each other by including comments on the other community's issue? That's a complex question. Either of you have any comments on that?
Yeah, I think it's a very good point, and I think attempting to get as much alignment as possible is very, very wise. Would benefit us both in terms of creating that volume, but also addressing their request that these regulations be harmonized. And so I think we should work together. I think the professional society should attempt to do that to the extent possible in their responses. But I also think as with anything, do this at a local level. So, you know, talk to your OPO, or if you're an OPO, talk to your transplant centers, and, you know, consider sharing the responses, and consider whether you're willing to incorporate some of what the other is saying into your response as an organization or as an individual, or even to do something jointly. And there obviously are aspects of this that really just don't pertain to one or the other, and folks may not be comfortable doing it, but there would be nothing wrong with a center submitting comments as a center, an OPO submitting comments as an OPO, and an OPO and a center, or an OPO and a collection of centers together submitting a joint comment on some of those things that pertain to everyone. So yeah, communicate as much as possible. Unfortunately, we know the short deadline makes this challenging in some ways, but since we've got just about another 10 days to get this stuff in, but I would really encourage that sort of local collaboration.
Laura Tauschla states, many of the items seem like soft band-aids. And I think that's what we have to realize, is they may be soft direction, giving direction that they're going to take. And that's why we have to provide some response to that educates them. For instance, I'm sure the point that I was talking about, I'm sure no one at CMS has ever gone into DonorNet. They don't think they have access to it. So they wouldn't see how many offers would come from one donor to your particular center. They wouldn't see how many people with blood type O you have on your list and would be getting that particular offer. So we have to provide ideas to them, tell them that, you know, we want to be more transparent, but the problems are the quantity and the amount. You have to be some kind of a cutoff at a sequence or something like that. Another question we have from Alexandra Mullen: are we going to discuss the parts of the regulation where they clarified allowable costs?
I don't think CMS has made any determination about the allowance of costs just yet, so it is important to submit your comments. I can only speak from the OPO side of things, and certainly determination of costs is really an important issue for us, but this question probably comes more on the transplant center side, I would guess.
It may, and it certainly affected both. I suspect what this is referring to was the proposed changes that were put out last summer because this RFI, I don't think gets much into that. I think, but they did propose changes last summer that would affect how the cost report works in pretty significant ways, and in my opinion, pretty significantly disadvantageously for the transplant community in a way that would not incentivize additional organ utilization. That is an area actually where, as a community, we came together and were successful in getting them to pull that back. So as far as what was put out last summer, that was retracted at that point. It was a success story for advocacy from the transplant community, in my opinion. I will say that doesn't mean they won't bring it back. So we need, as always, we need to stay vigilant and see what they propose in future years. Unlike the conditions of participation, where they only periodically make these changes, the inpatient payment rule is always has it has changes proposed every year, and they are extensive. And so this can keep coming back year after year if CMS stays dedicated to it. So we need to stay vigilant in terms of responding to that. But I don't think that's the exact focus of this RFI, nor the discussion today.
Lauren Abernathy offers a suggestion too, and this is interesting. And I thought about this too, Lauren. UNOS is implementing offer filters for kidneys. Perhaps providing transparency to the filters applied to each recipient quarterly, yearly, et cetera, would provide at least more transparency to what type of organ is being declined by their transplant center. Interesting thought. And here's an anonymous. The health equity data embedded in the RFI is rather jarring. What suggestions are being made in comments to address these disparities?
Well, I think that's, obviously that's up to everybody. I think, and I think it's an extremely important area, because there is no question in my mind that there is significant pervasive inequity in healthcare. That is an extremely complicated thing to fix, and I think there is real value in regulations that work toward improving that. And I think that's important, and I believe they will absolutely be part of any regulation that gets put out because it is an area of focus. At the same time, I believe that is an area that is fraught with a lot of potential unintended consequences, because I believe there are so many aspects of this that are not well within the control of transplant centers, OPOs, dialysis units to fix. And so I think we need to be cautious. I think this is extremely important, and I think it is extremely real, but I think it is also a fairly difficult thing to fix with regulation that doesn't have a lot of potential downside.
Does anybody have any other questions they would like us to address? I wish this RFI had been released in January and not December, when all of us were busy anyway with our own work, our regular work, but also with getting ready for holidays, whether it was Jewish or Christian holidays. We all had things that we were very preoccupied with. So it seems like it's very short in time that we have to respond to February 1st and to work together as an ecosystem, as they call it. But as best we can, I think we should. And especially if you can get your patients, get a few of your patients together and help them develop some response to CMS, I think that would be good as well. But any other suggestions? And I have to say one thing I didn't say about Luke that I wanted to say beforehand. When we have a CMS issue, the go-to person is usually Luke, Gwen McNatt, Jennifer Milton. Those are our go-to people. And all three of them are always very anxious to work with CMS and help figure things out. So they've been really resources for us. Luke is very knowledgeable about that. And also Alexander Ozzie, very, very helpful people when it comes to CMS and transplant related problems. So I encourage you to contact them too.
Well, yeah, thank you. I agree. And I'm always up for discussion of that. Webinars are one thing, but also a lot of, emails, discussion on the transplant administrators listservs and all sorts of things. There's a lot of ways for us to get together, and we can pull together other conversations of groups to address these things. And I think, as Ms. Mullen is very interested in further discussion of this IPPS cost report stuff, and I agree. I think that's a very, very important issue. I don't know whether the Alliance is necessarily the right group to pull that together, or whether they want to. I just don't want to speak for them, but one way or another, we should continue to have discussion about that, and I'm eager to engage in it. I want to thank Jennifer Milton for her leadership on that issue last summer, and
very much so.
We again, that as proposed, that rule stood to take tens, if not hundreds of millions of dollars away from transplant centers, and we were able to fight that successfully. And so we need to continue to be engaged in it. It's just not for this. I think what we know that this is one of those things with the conditions of participation. I believe that as a community, transplant did not do enough to self-regulate, and this goes back many years. And I think that is some of what led to Congress getting fired up and kind of telling CMS that they needed to increase regulation. That's what ends up happening. And so, that has become a collaborative process, and we need to provide our feedback, and we can't just take a defiant tone toward it and say, we don't think we should have it, just trust us to do the right thing. The government is not going to do that. And again, people can think whatever they want of that, but the reality is when they issue an RFI like this, it is extremely likely that down the road, they are going to issue new regulations to us. I don't know when, but it is highly likely that that's going to happen. And so I would encourage us to be very, very thoughtful in helping to shape that the way that would be useful to us, and just saying, oh, you can't fix equity with regulations is fine. You can say that, but they're going to try. And so I think we need to be thoughtful about concrete ideas. I think the example Linda gave is exactly the type of thing. I'm not advocating for or against any specific concept, but not just saying, you know what, we can't possibly tell all our patients about all their offers. Well, that's true. I believe we can't, right? But if we stop there, we're not going to get better regulation. I think we need to be concrete in saying, okay, we hear that there's a concern and we expect that patients will say, hey, I didn't know that I wasn't getting any offers for 2 years or whatever. When patients make comments, how do we acknowledge this as a real issue that we should work together to address and propose a regulation that is manageable and workable for us, as opposed to just saying, well, we don't think this is realistic. So I would encourage that kind of thoughtful, constructive response. It is far more likely to positively impact the ultimate regulation.
Look, you're absolutely right. You know, one of the things that CMS is really asking for, if there are other measures or metrics or ways that we could work together better, and what you just mentioned is exactly right. So I would just encourage everyone to be open to the idea that CMS does listen. They are very willing and they want to be educated as well. So the issue that you've been talking about, Linda, you know, they don't understand the volume of that. The same thing is true on the donation side. So this is our opportunity to work with CMS and to move forward positively in improving the system.
And educate. Yes, I like that. Educate, advocate. That was really good. Thank you. I like to be able to educate, and that's what I think they're asking us to do, because we're, like I said, we are the hands-on people. So we need to help them understand our perspective too. And that includes the patient's perspectives as well. So also, each time we've done something like this with CMS, our associations come in, whether it's AOPA, AST, ASTS, NATCO, they always are there to help us too and make sure that our letters get to the proper places and everything. So, and CMS has actually provided us with a lot of information on how to submit our responses to them. They gave us quite a few different, and if you have any questions, there's also a section in there with, I think, 5 different people that you can call up in Baltimore and actually ask them questions. So I really appreciate everyone participating in this, and I really appreciate AST, AOPA, and Alliance working together to provide this opportunity for us to discuss this. So thank you very much. Deanna?
Thanks, Linda. I just want to say thank you again to all of you for joining us today and for bringing this to our attention. We're happy to put together this forum for all of us to kind of come together and have this very important discussion. So I hope all of you in attendance found this valuable and, you know, kind of have your marching, not orders, if you will, but
Ideas.
ideas to submit and put forth next week or the week after, February 1st. So thank you all for joining us. And again, for those of you who asked, the presentation that was shared today will be available online on our website and will also be emailed out to all of you as well following the conclusion of today's program. And any resources, anything like that will also be available through our community resource toolbox, as Carrie shared earlier today. And so with that, again, thank you, Jan, thank you, Luke, thank you, Linda, so much. Thank you, Tricia, and thank you, Jennifer Milton, for bringing us to us. And we'll see you again in the future sometime soon.
Thanks very much for hosting this for us.
Bye, everyone. Have a good one.
Thank you all.
Thank you.